Hello, and welcome to the Occupational Therapist Role in Breastfeeding, presented by Marissa Hill and me, Darian Roberts.
All right. Welcome everyone. So the learning objectives, we have three. One, identify three areas of occupation related to breastfeeding. Two, identify three performance skills related to breastfeeding. And three, identify three types of intervention and three approaches to intervention as listed in the Occupational Therapy Practice Framework, 4th edition.
And just to make sure that you can follow along, you can look in the download section. This will be to the right of the screen if you're on the desktop, or you have to scroll all the way to the bottom if you're looking on a mobile device. And that way you can have the slides for this presentation as well. We've also linked the Get Started guide. It has lots of great information in here. And we also kind of talk about this near the end of this presentation.
So, a little bit about me. I'm an occupational therapist and an international board certified lactation consultant, IBCLC. I am the owner of a private practice called Lactation and Development Resources located in Dallas, Texas. And I'm the co founder with Darian of the Lactation OT. You can read my bio on the slide. If you printed the slide, I won't read the whole thing out to you guys. But just to summarize, I grew up in Dallas, Texas. I went to college in Boston, in the Boston suburbs at a school called Brandeis University. I studied psychology and public health. And then I ultimately went back to school to get my master's in occupational therapy at Salus University. That was in the Philadelphia area. I participated in field work in my clinical rotation at the Breastfeeding Resource Center in the Philadelphia suburbs. That definitely helped shape my interest and pique my interest in working with breastfeeding families. Let's see. So fast forward, I worked in schools. I worked in early intervention. I had debated working in the NICU potentially, but I wasn't a huge fan of the hospital setting. I didn't really see myself there. So ultimately, I ended up sticking with community setting, private practice, lactation, infant feeding, occupational therapy. So I have two kids of my own. I have right now a 4-year-old. Her name's Aurora, and a 1-year-old. His name is Ezra. And I am married to my college sweetheart. We met freshman year, so kind of a standard little story. And then we went to grad school in the same city. We worked in New York. So we sort of bounced around the Northeast together, Massachusetts, Pennsylvania, New York. And now we live in Texas again, in Dallas.
All right. And again, I'm Darian. I'm an occupational therapist as well as an international board certified lactation consultant. I own and operate a private practice here in the South Bay, Los Angeles area, humbled by motherhood, and the co-founder of the Lactation OT, obviously with Marissa. So again, my bio's here. I will just give you a brief rundown. So I have a bachelor's of science in biology from UC Irvine. And then like many of us, changing our way in biology because it's not the degree to have sometimes. I quit my dreams of pharmacy school and decided to become an occupational therapist. I went to school at UIC in Chicago, and I've always been very passionate about hand therapy. And I actually never really wanted to work with babies and children until I had my own. Motherhood will do that to you. So after my son, I trained to become a postpartum doula. I started my business and specializing in cesarean postpartum care. I studied homeopathy. I became a newborn care specialist to learn more about infant care and a little bit more about sleep. And now, mainly, my practice focuses on manual therapy, so bodywork techniques and development, as well as obviously lactation and infant feeding. I am very passionate about being a Black woman and Black maternal health equity. And so a lot of my efforts here are for high quality care for Black women and obviously other women of color and all women, if that is how they identify. And again, I live in the South Bay, Los Angeles area with my husband, my soon to be 6-year-old and current 3-year-old, and our bearded dragon lizard named Fried Dragon.
So, jumping into the course material a bit more, we just want to run through the current recommendations for breastfeeding. So, here are three organizations and their stances on breastfeeding. So, we have the CDC, the World Health Organization, and the American Academy of Pediatrics. So, the CDC currently recommends that infants receive exclusively breast milk or exclusively breastfed for the first 6 months and then continue on with breastfeeding while introducing appropriate solid foods until a child is 12 months or older. The World Health Organization recommends has a similar recommendation, same with the AAP in terms of exclusive breastfeeding until 6 months. But the difference with the World Health Organization is that they recommend breastfeeding up until the age of 2 or beyond, alongside the introduction of complementary foods. The American Academy of Pediatrics, up until recently, matched the recommendation of the CDC, which was exclusive breastfeeding until 6 months and then breastfeeding until the child is 12 months or older. They recently shifted. Instead of saying 12 months or older, they now say 2 years or beyond. So now their recommendation is in line with the World Health Organization, which it's very interesting that change happened because in the United States, we currently have protections for pumping at work, but only until 1 year postpartum. So now the law isn't really in line with the American Academy of Pediatrics recommendation for ongoing breastfeeding up until age 2. So there has been some interesting discussion about that shift, that change.
Yeah, and then the Pump Act just got passed, and so that's also more legislation to further help what Marissa was talking about, pumping in the workplace. Anything else you want to add here?
Oh,
Okay. Okay, so as this presentation is titled, The OT's Role in Breastfeeding, we want you to think of this as a subspecialty of an already specialization. And so it's very unique because just how you can specialize in pediatric as an early interventionist or within feeding therapy, schools, SI, or these other different areas, and then the same for maybe women's health or the adult population, right? You could be a pelvic floor therapist or mental health. In breastfeeding, we have two clients. It is the infant and the parent. And so lactation is really a highly specialized area to integrate into practice.
yeah, it's really one foot in two worlds, one foot in the pediatric world, one foot in the adult world.
Right.
So breastfeeding is a crucial part of infant feeding, a crucial piece of infant feeding. And we just wanted to put that out there because we know that, a lot of therapists are infant feeding specialists, and that's wonderful and that's great. But we can't forget about breastfeeding when we talk about infant feeding. It's definitely not just bottle feeding. Right now, we don't have a lot of OT literature about breastfeeding. So we definitely need more. We feel that OT is really perfect for this role of merging lactation and occupational therapy. We'll go over that in depth, looking at scope of practice for occupational therapists and, lactation, the lactating parent or the mother, however they identify, and then the baby. Let's see. So we're really passionate, Darian and I, about looking at breastfeeding as the biological norm, and then bottle feeding is, is separate from that. So versus, in our society, we kind of are focused on bottle feeding as the norm, and then breastfeeding is this optional thing that some people do. So that's not how lactation consultants look at it, and that's not how Darian and I look at it anymore.
Okay, so some of the benefits of human milk, you can read these, but basically, just the infant consuming human milk is very protective of various diseases and disorders. And some of these are very big ones, like such as neck, especially this past year or two with so many formula recalls um, for neck, and then also the higher risk of special populations such as the preterm population. It's a very big issue, and so this human milk has one of the biggest benefits of preventing things like neck, ear infections, diabetes, cancers, and a lot of GI issues as well, such as Crohn's and IBS. And it's because human milk is a live substance. It has so many components to make it this dynamic food, and really almost kind of like a personalized kind of medicine, because think of it as such a unique fingerprint, to match the dyad. And so, whatever the parent has had experiences in their life, they develop antibodies and things like that that then go into the milk, and it is very tailored for that baby. And as well as whatever environment the baby is in, they pick up whatever bacteria or viruses. And through this feedback loop, the milk can then be personalized for that infant based on the environment they've been in. So, really, it's this truly magical substance, and it has so many benefits for the baby.
Yeah. Yeah. I wanted to add as well. Can you go back a slide, Darian, real quick?
Yeah.
So I just wanted to point out that I just wanted to mention, I guess, that it's really important. It's wonderful to be passionate about lactation, about breastfeeding. It's really, really important to, yes, educate families so they can make an informed decision about whether they want to provide human milk or formula to their families. In no way, shape, or form do Darian and I advocate for shaming a family if the parent can't make a full milk supply, 100% of what the baby needs, or if they choose not to directly latch baby or pump. This is, in no way, we don't want to ever make anyone feel bad about their choice. But at the same time, it's really important to talk about the benefits of human milk, and not just, sweep that under the rug. But I just wanted to give that disclaimer. And, in my private practice, I think Darian would share the sentiment. I'm very, very passionate about asking families, what do you want? What's important to you? Because it's not my baby, it's not my life, it's not my body that we're talking about. So, and sometimes families will say 110%, I want my baby to receive 100% of my milk. Sorry, using the 110%, 100%. But you know what I mean? It's so important for some families that it's their milk their baby's receiving. And then there are other families that say, you know what? I just want to do this for about a month, and then I want to transition to 100% formula. So no judgment on my end ever, ever, ever. I just want families to know that I'm supporting their goal, whatever that goal is, and I will help them do whatever, we can, whatever is possible, to achieve that goal.
Right. I completely agree. This is not a unilateral decision of, I'm the healthcare provider and I know what's best for you and your baby. Like that is, this is a co-creation process of you being humbly asked to be part of this family's journey. And so we really are there as support and expert guidance of how to achieve whatever their stated goals are.
Yes. And, a lot of occupational therapists that I've spoken with who are interested in this area, I find a lot of them are coming to lactation with their own breastfeeding experience or experiences. Maybe they've breastfed one child or four children or seven children. And I think one of the most important things when getting started in this space is to check our own biases, in so many ways, but especially in this choice to give 100% of our own human milk to our babies. That's a choice that we made. Some of us also made the choice to bend over backwards, see a million providers, and have a frenectomy for baby to release, tongue tie, etc., to make this happen. And, it's so important to check our own baggage at the door and work on processing our own experience so that we are not triggered by whatever's happening with the family in front of us. It's just so important because their experience is not our experience, and that's one of the big things I find practitioners struggle with when they first get involved in this space.
Yes. Okay. Go ahead, Marissa. Oh no, this is no.
Okay, sorry. So decreased risk of SIDS. According to a study, we just want to point out that according to a study published in the Journal of Pediatrics, this is just one of many, there is an associated decreased risk of SIDS with breastfeeding. So any breastfeeding from 2 to 4 months reduces the risk of SIDS by 40%. Any breastfeeding from 4 to 6 months, 4 to 6 months reduces the risk of SIDS by 60%, and any breastfeeding for 6+ months reduces the risk of SIDS by 64%. So there's this association between duration of breastfeeding and the reduced risk of SIDS.
And a lot of the times when we are talking about lactation or human milk, the focus is always on like what is the benefit for the baby. And remember, there are two clients here. And so there are also a lot of great benefits for the lactating parent, such as decreased risk of breast cancers, ovarian cancer, postpartum bleeding. And that's due to the uterus shrinking down from the initiation of the suckling and the oxytocin, as well as reducing the risk of postpartum depression. There is actually a lot of great research about the correlation between postpartum or just general depression that can even if you're prenatal and you have prenatal depression and what that looks like for breastfeeding outcomes and the other way around. So there is lots of great good research there. And then also potential earlier return to pre-pregnancy weight. And the big one that's not listed here is a decrease of heart conditions, which is one of the leading reasons for postpartum deaths is heart disease. So that's a very big one that's not listed on here, but good to note.
Absolutely. So, breastfeeding, thinking about this from an occupational therapy perspective, we talk a lot about regulation, right? So, breastfeeding does help promote regulation, hormone regulation, secure attachment. We're thinking about co regulation. So, in terms of hormone regulation, oxytocin and prolactin are shown to have an inhibitory influence on the HPA axis, which is activated during times of stress. Oxytocin also has a central calming effect on the brain, right? That's our love hormone, oxytocin. And then breastfeeding has been shown to reduce a mother's risk of postpartum depression. That research is interesting. I have thoughts on that because I do think sometimes, and there is research to show that feeding difficulties is a risk factor for postpartum depression. So, at least with some of my clients, the desire to breastfeed and the struggles they're facing around breastfeed seems to heighten depression and anxiety postpartum. So, there's that. But hormones found in breast milk do have a protective effect against obesity. Looking at secure attachment, breastfeeding appears to promote sensitive responsiveness of this. The study refers to mothers and attachment security of infants. So more, of course, more research is always needed, but these are some interesting findings that we wanted to share with you all.
And also, breastfeeding encourages optimal orofacial development and oral motor skills. And so, although I consider breastfeeding a catch all term, this breastfeeding that's mentioned here is direct latching. And so, it's very important to specifically designate what you're referring to because a pumping or an exclusive pumping parent would be considered breastfeeding as well. So when we're talking about optimal oral facial development and oral motor skills, we're talking about direct latching the baby to the breast. And so it's because of the negative intraoral pressure that's required by the mid blade tongue to then create that vacuum and extract the milk from the breast. We will also want to think about the direct breastfeeding involves the breast going deeply into the baby's mouth and the nipple kind of reaching the hard and soft junction in the baby's mouth. And that also, if we think about the palate, that's also the floor of the nasal cavity, right? And so the baby's mouth structures move in a more sophisticated manner during breastfeeding than during bottle feeding. There is research that talks about the use of the masseters and the buccinator in nursing versus bottle feeding. And then proper breastfeeding supports suck, swallow, breathe coordination, which assists the structures of the mouth and the airway, and they work together in this unified sensory motor organ. And this leads to better mouth and airway development. And also, breastfeeding also helps to establish the suckling pattern that we use throughout our lives after the suckling has integrated.
Okay, so breastfeeding is a co-occupation. Co-occupation is something we don't talk a lot about in OT school. It's sort of brushed over. But what is a co-occupation? We're thinking about a meaningful activity that can only be done with two people. So breastfeeding is one of those. If we're talking, especially if we're referring to the direct latching, of course, pumping can be done solo.
Right. And so exactly what Marissa said, here's that definition for you from the OTPF directly about which occupations are co-occupations. And so it's the occupations, like Marissa said, that involve two or more people. And this was termed in 1996. And they're the most interactive occupations. And so when we think about the co-occupations required during parenting, it's usually the eating, feeding, those are different things, right? Parenting of the partner, the child, and maybe significant others. And so the specific occupations inherent in this social interaction are reciprocal, interactive, and nested.
Oh, I want to say as well that, we talk a lot about OT, SLP, PT's role in breastfeeding on the Lactation OT platform. And we just want to point out that, of course, lots of people in these various professions and in the SLP profession and PT profession are fantastic with breastfeeding dyads. A lot of them also become IBCLCs, board certified lactation consultants like Darian and I. However, one thing that is really unique about OTs in this space is that we do have both the parent and the baby well within our scope of practice, even without the board certification in lactation. Of course, we want to make sure that we are acting within our scope of competence, not just our scope of practice, but we can absolutely work with a lactating parent or lactating mother, however they would be referred to. And we absolutely can work with babies on feeding, their developmental milestones, all of that. So both the parent and the baby are well within the scope for OT. It's clearly it's clearly written in our OTPF 4th edition, the OT Practice Framework 4th edition. So breastfeeding as a co-occupation, we're also looking at infant communication and self-regulation. So this is a quote from a paper, which you'll see in our reference page. I hope I'm pronouncing the last name correctly. Petoniak, I want to say, 2014. So the quote says, within the breastfeeding co-occupational space, the infant has the opportunity to develop communication and self-regulation skills through sustained eye gaze, attentiveness to the mother's face, and listening to the mother's voice. The mother engages in breastfeeding with the initial intention of satisfying the infant's hunger, yet the mother also more subtly intends to support the infant's skill development for future occupation. So this just describes that interaction, that serve and return that happens during breastfeeding between the breastfeeding parent and the baby. And if any of you have breastfed, you might, be able to reflect calmly, fondly on those moments. They can be very peaceful moments, and it can be very serene. Oxytocin, that love hormone, is flowing for both mother and baby, and it can be a really wonderful thing for both mother and baby.
Yeah, so to continue with the breastfeeding as a co-occupation from that same article, breastfeeding is a co-occupation that transcends several areas of occupation. So, occupational therapy intervention typically addresses problems with initiating and sustaining breastfeeding within the areas of feeding and eating, yet, breastfeeding as a provision of care is clearly consistent with the occupation of child rearing as well. So, offering opportunities to examine broader mothering roles and the family and societal context that surround successful engagement in breastfeeding.
So that was another excerpt from that same paper, Petoniak, 2014. Okay, so looking at the exact areas of occupations that intersect with breastfeeding, we pulled out 6. So feeding, eating, swallowing, self-care, care of others, child rearing, meal prep. So I'll just briefly touch on how these apply. Of course, feeding is bringing food or fluid from the vessel to the mouth. In this case, the parent is feeding the baby, and then the baby is eating, swallowing the milk. In terms of self-care, we're thinking about the mother caring for her breast or the parent caring for their breast chest. making sure that milk is flowing. We're not dealing with stagnation, milk stasis, plugged ducts, mastitis, abscess, thrush, and countless other issues that we can have, unfortunately. We have to be mindful of how long it's been, right, since the last time the milk was removed. So self care, 100% self care. And then care of others, very obvious. We're thinking about not only the parent producing who makes milk or the mother who makes milk, but partner, right? That is huge, especially when you're working with the dyad. A lot of families, the partner comes too, especially if it's the first baby. The partner comes too, and they want to know how can they help. What can they do? Can they wash pump parts? When should they offer a bottle? Should they offer a bottle? How should they offer a bottle in a way that doesn't sabotage the direct breastfeeding, right? So really important. And then of course, child rearing. So caring for the child. There's an obvious intersection there with breastfeeding. And then meal prep, thinking about storage and handling of human milk. A lot of people don't think about it until they are in a situation where they are pumping and okay, the milk is sitting on the counter. How long has it been sitting on the counter? Is it safe to give? Do I need to toss it after 5 minutes, 10 minutes, 5 hours, 10 hours? What is the rule? And how do I know? Right. So meal prep is huge. And then how do we safely warm up human milk? It's very different. We handle it very differently than formula. So often in this space, we're going over preparation, storage, handling of human milk with families to make sure that they are doing so in a safe way. Yeah, so these are just a few areas of occupation, ADLs, IADLs, that intersect with the co-occupation of breastfeeding.
Yeah, and a couple points that I wanted to add on to Marissa, what she said. For eating and swallowing, we really want to look at this is really important that we can be able to complete a very thorough evaluation, right? And thorough assessment of oral function, oral skills to make sure that include that suck, swallow, breathe coordination that we might have mentioned earlier, and also for self care. In addition to breast health, right? This is also nutrition. And we talk about that later in areas of occupation about nutrition management. But nutrition is very key when the body it's so demanding to make the milk in the first place, as well as sleep. We know how important sleep is. So those are also big key items that go in self care. And then for child rearing, what I like to sometimes explain to my clients is that they want you to give them the answers, and we can't give it to them. And I clearly explain sometimes that this is one of the first parenting decisions that you have to make, and it's one of many, and it's hard, right? Do I supplement? Do I do this, or should I try this? And we can't give them the answers. We can help guide them, giving them information and helping them make informed decisions, but really, this is such a pivotal place to be working in this space because it is one of the first very hard decisions that a parent can make. And it is regarding feeding.
Absolutely. It definitely has a huge impact on mental health. The even
Absolutely.
having to make the decision. Sometimes some of these families really do wish that we would just tell them what to do. Uh,
Exactly.
and like Darian said, it's not our place to do that. We just want to give unconditional support, and help them reach whatever goal they have, as long as it's safe, of course. um, yeah.
Okay. So we have more areas of occupation because breastfeeding really does span through all of these areas. And so when we talk about health management, we have the social and emotional, health promotion and maintenance, right? So these are identifying what me and Marissa just kind of touched on, like their personal strengths and assets, and expressing their needs effectively. Like, what does this parent need in this moment to help, so that way I can support them in making this decision, and seeking occupations and social engagement to support health and wellness. So, what are these things? How can we help them make decisions that are going to be supportive of their family health as a whole, and not just focusing on the baby or not just focusing on her, but really taking into consideration that this is a dyad, and making choices that improve quality of life and participation in breastfeeding. And then we have symptom and condition management. And so this is managing the physical and the mental needs. And so these are maybe coping strategies, or working through any birth trauma, or societal stigma. There's a lot of that regarding breastfeeding, bottle feeding, formula feeding, all of infant feeding. And again, managing pain. So maybe it's a painful latch or something like that. If the parent has any other chronic diseases, all of that is concluded in this. And so also communication with the healthcare system. So even now, currently practicing as an occupational therapist, you may send notes to a different provider, such as a speech therapist or a physical therapist or the case manager or something like that. And so that still applies for here. So we are in communication with the maybe the pediatrician regarding weight gain, or maybe the frenectomy provider, or maybe the any other providers such as a mental health specialist or a chiropractor or an osteopath or whoever else may be on this person's care team. There's medication management, and that is if the parent was already previously on medication, and you're helping really make the schedule that makes the most sense for breastfeeding, because some medications are contraindicated to breastfeeding and some are perfectly fine. Most are perfectly fine, right? But that is very in-depth knowledge that the IBCLC holds to say, like, well, which medications can be managed with breastfeeding, and maybe there we're talking about medications for maybe something that happened in birth, regarding the birth and any potential traumas around the birth, or medications for something that's happening with the feeding, such as for thrush or something like that. And then nutrition management, very key. This is the implementing and adhering to nutrition and hydration recommendations from any medical team. So if they're working with a dietitian or nutritionist or something like that, uh, nutrition is very key to support all that the body has to do. And so not just for making milk, but also maintaining mental health and personal care device management. So this could be using anything such as like the breast pump or something like that.
Yeah, absolutely. Uh, medication management, there's a lot on medication that's covered on the IPCLC exam. It gets very complicated very quickly. There are, of course, quick resources and references we can look at. Uh, but it's so important that a family is working with an IBCLC who will pour over every single medication that parent is on, because things are missed by the OBGYN, the midwife, the pediatrician. So much is missed. And I'm thinking of a recent case that I had where the mom was on a specific anxiety. I think it was for anxiety. I forget, anxiety, depression, Wellbutrin. You can look up Wellbutrin. And she'd been on it for over a year. And apparently there isn't great research on it, but it can inhibit milk supply. And so this parent was pumping so much, 8 to 10 times a day, hand expressing afterwards, just really maxing out on breast stimulation. And with some digging, we sort of pinpointed that it was very likely the Wellbutrin that was inhibiting her milk supply. So I was able to connect her with a lactation specific pharmacist. And because, of course, I'm not going to tell her to, stop taking a medication that's definitely not in my scope. But at least I was able to point out to her why she wasn't producing as much milk as she wanted, why she had this very, like a very small supply, very small milk supply. And, basically having more understanding, and that way she was able to advocate for herself, talk with her provider, talk with the pharmacist, and see if they could adjust her dosage or switch her to a different medication, given that it's very, very, very important to her that she makes as much milk for her baby as possible. Okay, so continuing on, looking at the OT practice framework, the areas of occupation, rest, and sleep. Melatonin is a hormone that's released by the pineal gland at night and is associated with control of the sleep-wake cycle. In a Keeping that in mind, there have been studies, small and large. We're specifically referencing this larger study with a sample of 6,410 mothers and infants 0 to 12 months of age. And this study found that women who were breastfeeding reported significantly more hours of sleep, better physical health, more energy, and lower rates of depression than mixed feeding families or formula feeding families did. Um, so it is, yeah, that's just something that we can look more into. But breastfeeding definitely impacts hormones in a positive way for the lactating parent, based on a lot of research that has been done.
Okay, and continuing on, you see how I hope it is very clear at this point that breastfeeding does span many areas of occupation that we can then provide meaningful interventions for. So, more areas of occupation are leisure and social participation. And so, I'm not going to go through all of these, but we can think about how breastfeeding is viewed as a society currently and how it can impact the parent's ability to go and either participate because of time and the demanding of direct nursing. Maybe they don't have time to then participate in previous leisure activities, or explore. Do they have the mind space, the mental capacity to do so at the time when they have so many new responsibilities as a new parent? Are they able to go out and participate in any community events or maybe even family events? Especially if you think about, we're just now, time of this recording, just now coming out of the holiday season. But for all the families that have newborns, were they still traveling with high, this being the flu season and things like that? Are they limited and participating in these things? And then also maybe as that baby grows and gets a little bit older, maybe they are going to parent and me community groups like play groups and things like that. And also breastfeeding, how that can actually change your the relationship with maybe intimate partners, just because of really the hormones that are happening, and maybe even friendships, right?
Yeah, absolutely. So some client factors we're thinking about that for the parent: values, beliefs, spirituality, mental functions for both parent and baby, attention, perception, consciousness, temperament, and personality, energy, etc. I joke with a lot of the families that you can really start to see these babies' personalities early on. We joke, are they kind of chill? Are they open to trying a lot of things? Are they patient? Or are they stubborn, impatient? We joke about these things, but it's true that you'll see when if you are working with breastfeeding families, that there are some babies that are just really, really laid back. You can try a lot during a session, and there are others that are like, "Don't look at me, don't touch me, don't move me, don't reposition me." So it's interesting to see that. And then sensory functions, of course, where OTs shine, thinking of visual, auditory, vestibular, taste, smell, olfactory, proprioceptive, tactile, touch, interoception, pain, et cetera, sensitivity to temperature, pressure. There is so much that goes on with breastfeeding, right? That deep pressure from mother holding baby closely to her body, or parent holding baby closely to their body. There's the smell. It's reminiscent and it tastes like amniotic fluid for these babies. So it's very calming, reassuring for them often. I joke with families that breast milk tastes like ice cream. So they love it. They're excited about it. And if they seem to be frustrated, it's not with the drink, the beverage, it's with the delivery method. They're feeling like they're not very good at removing milk from the breast. That's why they're frustrated. It's not an issue with the milk. Um, and we usually have a good laugh about that. But yeah, so there's so much to it with breastfeeding. Also interoception. So those internal cues the baby has to learn to recognize and then communicate: hunger, satiation, fullness. You'll see a lot of babies who struggle with their satiation cues, with their fullness cues, and they'll just guzzle, 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 keep going. Especially if they have reflux, they're in pain, they're using, they're comforted by continuing to remove milk from the breast, continuing to drink milk from the breast. So it's really interesting. There's just so much going on, and it's cool to point out the wonderful aspects, the interesting aspects to families, and then to help when things are not going well to utilize our skills in task analysis as an OT to kind of figure out where is this falling apart, why isn't this working, and what can we do from a sensory perspective to help this go better. Sometimes we need to actually have parents standing up and swaying side to side during some latching attempts. There's so much we can do. Or if mom is or parent is struggling with pumping at work, sometimes having a baby's clothing or blanket having her smell that can help with milk ejection. Having her think about baby can help.
I did really just want to reinforce like how brilliant the design is of how babies have reflexes for the even the very first quote unquote breast crawl or potential first latch in that golden hour, and how they really use all of these sensory functions to make that happen without outside external intervention. So the areolas darken, right, to provide some visual input, because we know babies don't aren't fully have a developed visual system at birth, right? But that's the purpose of the darkening areolas, and they can hear the mother's voice. Hearing is very established, right, at birth, and the vestibular. So, actually, where their body is moving and how they're positioned. So, you can see some babies are a lot more sensitive to vestibular input. Marissa talked about the taste and smell is well developed at birth. And also, that's guiding them to get to the breast for that first crawl. And a lot of the proprioceptive input of that baby using various reflexes like the stepping reflex and really getting that proprioceptive input through their body to get to that breast for the first latch. It's really such a brilliant design and so sophisticated, and it's really truly amazing. Highly recommend you watch that video.
Yes.
Okay. Other client factors, obviously, we're looking at neuromuscular skeletal system. So it is very important that babies and parents both have good stability, muscular trunk stability, and sometimes we can use various positions to make sure parents and babies are more supported. And then we also have to think about how the basis, if we're looking at the hierarchy of needs, the basis of our cardiovascular and our physiologic stability in order to produce the best oral motor skills to even make this whole synergy happen. So, more client factors. And
All right, on to performance skills. Keep on scrolling through your OTPF fourth edition. So we're looking at motor, we're looking at social interaction. So with motor, positioning of the body, and certain items in that category include stabilizing, aligning, positioning, obtaining, holding objects, reaching, bending, gripping, manipulating, coordinating. And then so for with breastfeeding in particular, there's a lot of, we're thinking fine motor coordination for the parent. It's very, very interesting. I see it all the time. Some of these parents they don't have great fine motor coordination. They really struggle with the motor plan of bringing baby to the breast. No matter how many times I go over it, they'll keep leaning over their baby instead of bringing baby to the breast. So I use a multisensory approach to learning with them: visual demonstration, auditory, explaining verbally, um, showing them videos, showing them with my own baby doll and a crocheted breast, helping them, using hands-on support for them. It's really, really interesting. But positioning of body for both the parent and the baby, and then moving self and others, again, moving themselves, moving their baby, applying knowledge. So hearing the information that I am providing using a multisensory approach, and then applying it to this motor, to this task of breastfeeding. And then organizing space and objects, and organizing timing. Timing is so key with breastfeeding. It's so hard when these babies open their mouth for a brief second. A lot of families miss it. That was their moment and they missed it. And if they keep missing it, the baby gets really frustrated. So helping them with that timing is so, so key when working on improving latching at breast. So social interaction, we're looking at producing social interaction, physically supporting social interaction, maintaining flow of social interaction. And so that's with parent baby, it's with the spouse, it's with whoever else is in the household, maybe older siblings. So there's so many pieces to this in that performance skills section, and so much of it applies, if not all of it, applies to breastfeeding or chest feeding.
okay. And so, now that we know that we have a clear picture that occupational therapy and lactation clearly are a great marriage together, what does this actually look like in practice? Like, how do we actually start applying some of this therapeutic process? So, the first step, it could be screening. We actually have a screener available, but screening. So, we need to clearly and early identify potential feeding issues, and we're monitoring baby and the parent for to see like the progress of any potential issues, right? And then providing any recommendations for preventative care, and then obviously referring if needed. And then evaluation. So assessments are standardized and non-standardized. There are not many standardized assessments for infant feeding. So many are non-standardized. Uh, the lactation OT does offer forms. So a non-standardized intake and evaluation form for this. Uh, Getting the occupational profile, the background, the goals, and analysis of the actual performance of the task of of this co-occupation that we've been talking about, and then synthesizing all of those components to then create your goals and intervention, right? So the development, implementation, and modification of the intervention plan, whatever those interventions may be, there are many. And for monitoring the outcomes and maybe either transitioning services to either if the baby is getting older, maybe they go into more of a traditional feeding therapy, or maybe it's a discontinuation or discharge from your services because the outcomes are improved. So it's important to have both subjective and objective outcomes. So with lactation, we can monitor things objectively, such as weight gain or time of feed or efficiency of feed, by measuring, millimeters intake or grams per intake per minute, or subjective. So maybe the parent is reporting less pain or more comfort or things like that. So it's important to follow. That is what makes us therapists and occupational therapists, is by following a therapeutic process.
Absolutely. Absolutely. Okay, so models of practice and frames of reference that apply here. We're thinking about Dunn's model of sensory processing, the Kala model, model of co-occupation, the PEOM model, the PEO model, the PEOP model, intentional relationship model. And then in terms of frames of reference, so many apply here: biomechanical, cognitive behavioral, developmental, motor skill acquisition, occupational adaptation, rehabilitative, sensory integration, and so many more. These are just some that we wanted to mention as a starting point.
And so breastfeeding involves a dynamic and reciprocal interaction between the parent and the baby. And it should be very, very clear by now that occupational therapists are very well suited to specialize in this practice area, because we are able to really take and look at this whole body approach of the parent and of the baby. And it's really amazing.
Yeah, agreed. Okay, so interventions. We're looking at prenatal care, so providing education, training ahead of time prior to the baby being here. Okay, so the mental health, we're thinking about, again, education, help. We're looking at self-regulation, coping strategies, community support groups, um, actual nursing or direct latching. We're using physical agent modalities, self-regulation strategies. I can't tell you how many times I will recommend to a mother that she takes a deep breath, and then all of a sudden her milk ejection reflex happens, or her milk lets down. It's so interesting, and they'll kind of laugh and go, "Oh, okay, I guess I was really stressed in that moment," and yeah, I can just kind of relax, and all of a sudden the milk will flow. It's cool to see. And then we have our environmental modifications, so much. So with nursing, we're trying to establish or restore nursing. Maybe we're maintaining nursing or modifying it or preventing an issue down the line, given that there are some early red flags. And then, of course, bottle feeding as an intervention, with especially in the United States, so many parents go back to work after 6 weeks or 3 months, 12 weeks, something like that. So bottle feeding becomes a big part of the picture. So working to intervene early, as opposed to waiting until the night before somebody goes back to work to give the first bottle, happens a lot. It's unfortunate. We want to plan ahead. And of course, recommend bottle feeding practice without focusing so heavily on bottle feeding that the direct latching nursing relationship, never comes to be.
And so it may be tempting that you want to hear specific interventions, but obviously we cannot provide that in the scope of this 1 hour course. But one thing that I did want to point out is that if you look, education and training is part of all of the interventions, and so it really is important to make sure that you have adequate lactation specific education training before providing any of this education to parents, because many times well-meaning therapists can say something that is actually either incorrect or maybe not in the correct context because they haven't done a full evaluation of that dyad, and it can actually be potentially harmful or triggering or re-traumatizing for families. And so it is we want to stress to make sure you have proper education and competencies before attempting any of these interventions.
Yes, yes, 1,000 times yes. And so, there's a really big difference between being lactation informed versus a skilled lactation professional. Um, there's a huge difference. Both are important. It's just really critical to stay within one scope of competency when interacting with breastfeeding families, because it can't wait. We can't just wait until a child is 6 months old, 9 months old for breastfeeding to click. It's very, very time sensitive. A lot of these reflexes, these infant reflexes, integrate quickly in those early months. And so we need to get in there early, and we need to see progress, progress, progress. We can't functional plateau and then do 12 sessions and still not have any progress. So to learn more about interventions, we highly recommend the courses on the Lactation OT platform. We are the co-founders of the platform, so there is bias there, but we really selected courses that we wish we would have had, and courses that we want to take ourselves. So we get really excited when a course creator selects a topic and begins the process of developing a course for the platform. We are some of the most excited therapists, two of the most excited therapists, whenever there's a new course on the Lactation OT platform.
Absolutely. And again, to touch on mental health, because I see a lot on social media and things like that, that they're maternal mental health OTs. And it's great to try and practice that as a standalone service, but that's also um, a lot of other professions, such as psychologists, psychiatrists, LCSWs, and other people like that, that have greater ranges of intervention. And so it is very important that we practice within our competencies, and also want to highlight how lactation, if you truly want to make meaningful impact on maternal mental health, how lactation, specializing in lactation, is such a great way to have access to that population, because feeding is so heavily linked with their mental health. So there are some great studies that talk about how if the parent experiences any depression prenatally, how that actually can worsen if feeding has any problematic, such as the study indicated, like nipple pain, um, and how actually if breastfeeding is going positively, how that actually increases positive association of mental, or decreases the depressive symptoms. So if you truly want to make a big difference, obviously I'm biased because I work in lactation, but a lot of what we do is managing and intervening on maternal mental health through the lens of this lactation consultant.
Absolutely. And it's the earliest entry point, I think, before the sleep consultant, before the, pelvic floor therapist, the lactation consultant is one of the first people who gets in the door. I've
Right.
seen babies who are 12 hours old after a home birth or a birth center birth. You can see these families immediately. You can be the very, 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 very first one. Talk about early intervention, right?
The earliest intervention.
The earliest intervention. It's for parent and baby, for mother and baby. It's so beautiful. It's so cool to be able to do that for people. So, okay, so what's next? We wanted to feature this here that we do have a screening option. If you're interested, you want to start to dip your toe into things, you don't really want to dive into a full course, 8-hour continuing ed course, but you just want to start to pick up on red flags so that you can refer appropriately to a lactation consultant in your area. This is the perfect thing for you. It's only $9. It's Darian and I talking for an hour about how to screen, and we show actual video of our clients. I think, do you remember how many videos we go over? It's like 13 to 15, something like that. I
Yeah,
don't
it's
remember.
it's like 15 videos of both nursing and bottle feeding.
Yes, yes. And often the same baby at the breast and the bottles for comparison. So we show you some of the nuances, little things that you might not have known to look for, so that you can better screen and refer, and maybe eventually evaluate these families yourself, after pursuing further education in lactation.
Yes, we really hope that you decide to keep learning and growing because families need you. There is not enough support for new families.
Absolutely.
Okay. So, after you've taken a look at that screening form and or maybe you've already come to the internal decision that you're really ready to start pursuing this, the first step for you is lactation specific education. And so there's obviously the lactation OT courses, but really any structured lactation specific program out there. There are many that are at least 45 hours, and that's going to provide you with the introductory information, or you could do the full 95 hours, which would be enough to then sit for the IBCLC exam in conjunction with the clinical hours. So then you would need clinical hours and, of course, mentorship throughout this whole process because um, breastfeeding, like we said in the beginning, is a subspecialty. And it is very unique and nuanced because of this two patient situation.
Yeah. And so this is just a very brief overview of ways to get more training. For more in depth, you'd want to go look at the free downloadable guide that goes over 8+ programs that offer an entry level certification, for the pricing of those programs. And then it also talks about lactation informed versus lactation consultant. And if you want to become a lactation consultant, like Darian said, you're not only getting lactation education hours, but then combining those with clinical hours and mentorship. Yeah, so it's a 2 to 5 year process to become board certified in lactation. However, there are more entry level programs, counselor, peer support sort of programs that are less. So sort of deciding which direction you want to go in. And often, the 45-hour counselor program would be a stepping stone towards becoming board certified in lactation if that is your ultimate goal. So in terms of practice settings, we get this question a lot too. Well, what are some practice settings? What could I'm super, super interested in, where could I work with breastfeeding families? So we just wanted to point out some options here. We have early intervention. You'd need to work with your case coordinator to add some breastfeeding infants to your caseload, specifically. And when you're first getting started, I really, really hope you're also referring to a local IBCLC. You could work in conjunction with that person to support a family. You can work in mental health, so inpatient, outpatient. There are parents who are there separated from their infant who are going to need to pump. Um, there are reasons why a parent might be in inpatient or outpatient mental health setting needing support. Then we have nonprofit organizations. This could be a paid or unpaid position working with new lactating parents from various backgrounds. We have the NICU. It's a fairly obvious one. There are many therapists in the NICU who become IBCLCs. They work towards dual mentorship. So a therapist in the NICU, as well as in order to become a NICU therapist, typically there is a requirement, at least 6 months of mentorship. And then down the line, looking for either a therapist who's an IBCLC or an RN who's an IBCLC to help them deepen their knowledge in lactation for this very medically fragile population.
Okay, and then other areas are Private practice. So this is only recommended if you actually have completed the full 95 hours of lactation education and you already have experience treating a dyad. And if that is the case, there are many places that will be happy to have you, such as midwifery offices. That's where I got my start. A pediatrician office. I also briefly worked in a pediatrician's office, as well as the OB-GYN office. They are community lactation clinics. And again, they work with the dyads in the community setting. This could be prenatal, postpartum, or something like a wellness center. And this could be in the scope of either providing support groups or direct care. And then the bottom two are our nonprofit peer counselor organizations that you could complete their program and then become a peer counselor. It is a requirement, not a recommendation. It is a requirement that you have breastfed your own child for a specified time. So you would have to check with each of those organizations to see how long that is for each of those. But that's also a great way if you want to provide local support groups.
Absolutely. So some other settings, let's see, or what is this slide, Darian?
Yeah,
Is
this
this
would be
from?
more settings if you are paired with an IBCLC mentor.
Oh, okay. I see what you mean. Right, right. So again, to learn more about that, that would be pathway 3 specifically. If you had a mentor who signed a contract, definitely check out the free guide. Now, some people, many therapists do end up working with multiple mentors on a more unofficial basis without a signed contract via pathway 1. So there are options there. We're just looking at pediatrician office, primary care, midwife office, birth center, prenatal center, again, so just highlighting those areas that you might be working with a mentor in.
So if you're looking for an IBCLC mentor, these would be the first 4 places to start your search.
Okay. Also, if you're not in the lactation OT community on Facebook, go there as well. We have at this point, over 3,000, approaching 4,000, I think, therapists in there. So you might be able to connect with somebody in your local area or virtually who could provide some mentorship.
And then for this last slide, this is also in the Get Started guide. We did want to make a note that this is a little different than the therapy background or community or area, is that within lactation, there is usually paid mentorship. So unlike an OT school where we go on, field work 1 and 2, and technically you are paying tuition to your university while you're on field work, usually working a full-time schedule for free, right? So technically you're paying, but in the lactation field, it is very common that when you find an IBCLC mentor, that is a paid relationship, um, kind of in that same way. So we just wanted to make that note here and really stress the benefit of mentorship. And this could be someone that is very, very seasoned, or this could be someone that's a little further along the journey than you. But either way, support along the journey is highly recommended.
Yeah, absolutely. We think about our fieldwork coordinators in OT school, they were still paid their full salary when they took us under their wing. So it is different in lactation, given that so many lactation consultants are in private practice. So time that they spend talking with you one-on-one without a patient present is unpaid time. And so it needs to make sense for them financially in order for them to be able to or to want to take on a mentee. So we
Right.
are
And
so happy that oh, sorry, Darian, go for it.
yeah, I was gonna say, and that wraps this presentation.
Yeah, definitely check out the references if you'd like to learn more. Definitely read over the OTPF fourth edition. It's super fun. You could stay up real late reading that document. But we hope to see you in the community on Facebook. And yeah, can't wait to talk again soon.
All right. Have a good one.